Hello, welcome. We're excited to have you here today for our liver disease care, empowering primary providers and communities for early detection. My name is Morgan Harrington, and I am the National Manager of Programs here at American Liver Foundation. ALF's mission is to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. As part of our commitment to the liver community, ALF offers a range of educational programs and resources for patients, caregivers, and providers. You can find more information at liverfoundation.org. The ALF Living Donor Network is the first national database designed to connect non-directed living donor with transplant centers across the country, a critical step in addressing the shortage of liver donors. Our goal here is twofold: to increase the number of living donor liver transplants in the United States, as well as eliminate the pediatric liver candidate waitlist. Please feel free to share this new resource with your networks. We are incredibly grateful today for all of our physicians. Thank you for taking time out of your busy schedules to be here with us. Your dedication to liver disease education is deeply appreciated, and we are honored to have you share your expertise with us today. A special thank you to Dr. Bubu Banini for her invaluable contributions to the development of this program. Her dedication and thoughtful guidance through every step of planning process has ensured that the content today is not only comprehensive, but truly meaningful. While we are unfortunately not going to be joined today by our CDC partner due to the current government shutdown, we do want to take a moment to acknowledge and express our sincere gratitude towards the CDC and to Nathan in particular for their continued partnership. Their unwavering commitment to advancing health education and supporting efforts are vital towards hepatitis elimination, and it remains deeply valued and appreciated. So I would like to start our program today by introducing today's moderator, Dr. Leslie Miller. Dr. Miller is a professor of medicine at Emory University. She is the medical director of the Grady Liver Clinic, a hepatitis C clinic for underserved patients at Grady Health Systems in Atlanta, Georgia. Dr. Miller leads internationally recognized HCV screening and treatment programs focusing on the unique treatment models aimed at HCV elimination. Dr. Miller serves as a medical expert for the Georgia Department of Public Health Viral Hepatitis ECHO program and is a member of several national HCV-related steering committees. She has been recognized as the hepatitis elimination champion by the Task Force for Global Health. I'm going to go ahead and turn it over to you today, Dr. Miller.
Thanks so much, Morgan, for that kind introduction. And I now have the honor of introducing the rest of our faculty for today's session. So we really have an all-star lineup for you of experts in liver disease and are so excited to share over the next hour. So first we have Dr. J.P. Arab. He is an associate professor of medicine at Virginia Commonwealth University and inaugural director of alcohol sciences at the Stravitz-Sanyal Institute. A leading expert in alcohol-associated liver disease, or ALD, his research has shaped clinical practice and understanding of ALD. He serves as associate editor for Hepatology, chairs key ALD committees across major liver societies, and has authored over 280 peer-reviewed publications and clinical guidelines. Next, we have Dr. Bubu Banini, who is a board-certified gastroenterologist, transplant hepatologist, and obesity medicine specialist with a focus on steatotic liver diseases, including MASLD and alcohol-associated liver disease. She earned her MD PhD from Thomas Jefferson University and completed advanced training at Mayo Clinic and VCU. Her research explores mechanisms of liver fibrosis and cancer, and she serves on the National Medical Visionary Advisory Board for the American Liver Foundation. Next, we have Dr. Renu Dhanasekaran. She is a physician scientist specializing in liver cancer at Stanford University. She combines clinical care with translational research, leading a liver tumor clinic and an independent lab focused on tumor immune interactions, biomarker discovery, and targeted therapies. A recipient of the NCI Merit Award, she's widely published and funded by the NIH, AASLD, and other major organizations. Her work aims to advance precision medicine and improve outcomes for liver cancer patients. And finally, we have Dr. Craig Lammert, who is an associate professor of medicine at Indiana University and a practicing adult hepatologist. His research focuses on autoimmune liver diseases, particularly autoimmune hepatitis, or AIH. He has led federally funded studies and investigator-initiated trials exploring novel therapies and dietary interventions for symptom management. In addition to his academic work, he is the founder and president of the Autoimmune Hepatitis Association, a global patient-centered organization dedicated to education, support, and advancing AIH research. So I think we have covered all of the speakers, and I am going to kick us off here. I'm filling in for Nate from the CDC and just going to cover viral hepatitis briefly before we turn it over to the other speakers. So this is really focused on action items for primary care providers. And really just to set the stage, and I only have a couple slides here, we need primary care providers if we are going to achieve hepatitis C elimination goals. Next slide. Great, thank you. One before. Perfect. So these are World Health Organization goals for viral hepatitis elimination, both hepatitis B and C. And you can see that our sights are set on 2030 for a 90% reduction in new infections of hepatitis B and C and a 65% reduction in deaths. So we have our work cut out for us. We love our hepatologists, but we don't have enough of them to do this on their own. So we really need the primary care workforce to get involved. And I'm going to show you how we can do that. Next slide, please. So the first step is we can screen. So we can screen for hepatitis C, and you can see on the left here the new, relatively new as of 2020 CDC guidelines for hepatitis C screening. So that includes every adult 18 and up at least once in their lifetime, pregnant women with each pregnancy, and that's new in the 2020 guidelines, as well as people with risk factors regularly. And that includes folks who are at highest risk, including those who are actively injecting drugs, and those patients should be screened at least annually. You can see on the right how we screen, so we know who to screen. Now, how do we screen? We start with an HCV antibody, and ideally this should be reflex to an HCV RNA to confirm chronic infection. Next slide, please. Okay, and you can do one further click. Okay, so great, that's perfect. So in addition to hepatitis B, we can take, hepatitis C, we can take action on hepatitis B. So there are also new screening recommendations from the CDC as of 2023 to do universal hepatitis B screening. So really similar for hepatitis B as it is for HCV. So all adults 18 and over should get at least one screen in their lifetime, and that includes a triple panel with hepatitis B surface antigen, core antibody, and surface antibody. And then again, just like hepatitis C, people with risk factors should be screened more frequently. There's also a new CDC recommendation for vaccination for hepatitis B, and this is not quite universal. It's universal from age 19 to 59, and then adults over 60 and older should be screened if they have risk factors. So both of those relatively new recommendations and action items we can take as primary care providers to really move the needle on viral hepatitis elimination. Next slide, please. An extra added bonus, if you're really brave and excited, you can actually treat hepatitis C. And I am an example of a primary care physician who has taken on hepatitis C treatment and taught many others to do so as well. And I can tell you it is the most gratifying and satisfying thing I do in my career, because I can't cure hypertension or diabetes, but I can cure hepatitis C. So this just shows the very latest AASLD IDSA guidelines for simplified hepatitis C treatment using a hepatitis test and treat model. So really, as soon as you get a diagnosis of chronic HCV infection, you can go ahead and treat. Minimal workup. You can actually start medications the same day if you have access to them. And it's quite simple to do, and again, quite gratifying. So ways we can get involved as primary care physicians: screen and treat hepatitis C, screen and vaccinate for hepatitis B. And then I will stop there and turn it over to our next speaker.
Thank you very much for the introduction and inviting me today. So today we are going to talk about alcohol-associated liver disease. Next slide. So, what do we mean when we said alcohol-associated liver disease? So, as now we have this steatotic liver disease spectrum, even within ALD, there is also a spectrum. So, if you heavy drink 95% of the time, you are going to develop steatosis, which is the fatty liver, and then 20 to 40% of the people is going to develop fibrosis. And another percentage will have cirrhosis and all the complications, including hepatocellular carcinoma. At any point of the disease, with or without cirrhosis, a patient can develop the inflammatory form of the disease, which is called alcohol-associated hepatitis, that has a very different prognosis. So the mortality on severe alcohol-associated hepatitis is around 40% at 3 months. So it's a very severe liver dysfunction with a very distinct prognosis, and that's why it's important to identify. There are different genetic factors, or the amount of alcohol, or other comorbidities such as viral hepatitis or obesity that can also manifest the severity of the liver disease. Next slide. Alcohol as a cause of chronic liver disease is very important, and especially when you go in the more severe forms, when you go in, for example, here in this paper, in patients that require liver transplantation, you can see how in males, here in purple, alcohol is the #1 cause, followed by MASH in green, and how in females, MASH is #1, followed by alcohol. I just would like to make a note that this data is up to 2019, so it's pre-pandemic. We know that during the pandemic, alcohol consumption, especially in young women, increased significantly. Next slide. So how much alcohol you can drink safely? And this has been a question that has been in the field for a very, very, very long time. So the short answer is, if you want zero risk, it's zero. So you shouldn't drink anything. We know that more than 7 drinks per week, so 1 drink per day, significantly increase most of the adverse outcomes. But again, that's high risk. So the opposite of high risk is not necessarily low risk. There is also intermediate. So these 2 papers from Lancet, one from 2018 and one from 2022, show that even with 1 drink, you start increasing your risk of having adverse outcomes. Some people were saying, well, this also depends on age and sex. So that's the 2022 paper. Show that this is especially true when you are less than 60 years old. So if you are less than 60, really there is no safe limit. If you are more than 60, it seems that there is some window there that is lower than what we thought before, but that can be with a low risk of alcohol. Next slide. So when we are seeing a patient that has alcohol-associated liver disease, we need to think that usually these patients also will have an alcohol use disorder. Alcohol use disorder is a psychosocial comorbidity where you cannot stop drinking despite the social, physical, and mental, and familiar economical consequences. So when we are seeing patients that have even a suspicious for alcohol-associated liver disease, you should think, does this patient have AUD, so alcohol use disorder? And then we need to assess for both, same as we do, liver function test. We need to do the same for AUD screening, use the audit score as a screening score. And then we need to provide treatment for both. So if you are only treating one, for example, only the liver disease, and we are neglecting the other part, probably the outcomes are not going to be as good as we want. Next one. So, and there is treatment. So treatment for AUD, and this is a cohort from the VA by Chari Rugal, showing that, from almost 40,000 patients with cirrhosis due to ALD and also AUD, so alcohol use disorder, only 1.4% was receiving pharmacotherapy for alcohol. And those that receive it, AUD actually improves survival. Is the hardest of the outcomes. But for some reason, we don't do it. And I think we need to do better there. Next one. And sometimes people say, well, but I don't know if these are effective. And here I put the number needed to treat for you for naltrexone, acamprosant, and baclofen. And the numbers are like between 12 and 20. If you consider like you have a patient with peptic ulcer disease and is bleeding, all of you are going to prescribe PPI, and the number needed to treat is 15. So it's almost the same number. Like, I don't imagine any of you not prescribing aspirin if someone has an MI with ST elevation, and the NNT is 42. So the medication for AUD are actually better than prescribing aspirin for an MI, and still we don't do it. So I think my only message today is ALD is usually associated with AUD, and we need to treat AUD. We need to support our patients in that sense. Thank you. Next slide.
Thank you so much for the previous speakers, and thank you to the attendees for coming today. We definitely know that this is a partnership between us as liver disease specialists, primary care providers, and all other providers in different specialties. So thanks again for spending some time with us this afternoon. So I have the pleasure of speaking about MASLD. MASLD is a fairly recent terminology that was coined about 2 years ago, which replaced the historical term of NAFLD, which most of you are possibly more familiar with. So MASLD stands for Metabolic Dysfunction-Associated Steatotic Liver Disease, which is really represents a wide disease spectrum, as you can see on the slide. Very early on, with deposition of fat in the liver, we refer to that as metabolic dysfunction-associated steatotic liver, so MASLD without the D. And with time, the deposition of fat in the liver results in inflammation and injury to the liver cells, which we term steatohepatitis. So by definition, when we say someone has MASH or metabolic dysfunction-associated steatohepatitis, they are beginning to show evidence of injury to the liver cells. With continuous injury, then the liver can develop fibrosis, and fibrosis starts as mild F1 and progresses through the most severe fibrosis, or F4. And clinically, F4 is what we refer to as cirrhosis. So this really is a broad disease spectrum. It's very important to determine where in the fibrosis stage the patient is, and we will talk about that some more in the subsequent slides. So as primary care providers, really the key is to have a high index of suspicion for steatotic liver disease, screen patients, and diagnose. And a lot of times we come across these patients incidentally. They may have gone to the ER with abdominal pain and they had imaging of some sort, and radiologist says that the liver looks echogenic or there's fat in the liver. Or sometimes they may have had a biopsy for something else and that was seen as an incidental finding. It's very important that that is not overlooked or brushed aside. I think gone are the days where we tell patients, oh, it's just a little bit of fat in the liver, because we know that that little bit of fat in the liver can progress really to cirrhosis over time. So the next question when one sees steatotic liver disease or a telltale signs that the patient might have this diagnosis is to ask if the patient has any cardiometabolic criteria. So click on next, please. You will see that on the top right side of your slide, I have here listed the 5 cardiometabolic criteria that we frequently consider. Does the patient have BMI in the overweight or obesity range? And keeping in mind that there are different cutoffs for individuals with Asian ethnicity. Does the patient have increased fasting serum glucose or A1C, or are they on medication for diabetes mellitus? Do they have elevated blood pressure, or have they already had a diagnosis of high blood pressure and are on antihypertensive drug? Is their plasma triglyceride high, or are they on lipid-lowering therapy, or is their HDL low? Again, there are different cutoffs for male versus female. So if the patient has any one out of these 5 cardiometabolic criteria with the finding of steatosis in the liver, then they really have a possibly have MASLD. So then go to the left side of your slide where it says yes, they have steatotic liver and they have cardiometabolic criteria or a criterion. Then the next question is, do they have any other potential causes of steatosis? And I list them at the right lower side of the slide, the other common etiologies that we looked at. So click on next, please. So you see them listed here. If the patient has the cardiometabolic criteria, and has potentially another cause of fat in the liver, then they may have an overlap of MASLD plus the other etiology of steatosis in the liver. However, if they do not have the cardiometabolic criteria, but they're still finding of steatosis, then you want to go down that pathway and again determine what might be causing the steatosis in the liver. So fibrosis, I mentioned, is key. And again, if there's one message you're going to take from this MASLD talk, it's about fibrosis. And this is because fibrosis is the strongest predictor of mortality in individuals with MASLD. Mortality, both from a liver perspective as well as a non-liver perspective, overall mortality. So the tool that is most frequently recommended to use for initial fibrosis screening is FIB-4, Fibrosis 4 Index, which is based on liver chemistries, platelet count, and patient age. So AST, ALT, age, and platelet count. And when you plug those values into the FIB-4 calculator, if the value is less than 1.3, then there is a low risk that they have advanced fibrosis. Then you will really just keep them in the primary care setting and do the risk stratification with FIB-4 every 1 or 2 years. However, if that FIB-4 is equal or greater than 1.3, then you need to take further steps. If it's clearly over 2.67, then we recommend referral to a GI specialist for further workup and management. If it's between 1.3 and 2.67, then we recommend doing secondary risk assessment, either with a transient elastography, which we popularly known as FibroScan, or with enhanced liver fibrosis testing, and determine further steps based on what those values show. So no matter where patient falls in the spectrum, there really are certain cornerstones that we recommend to patients. The key is trying to lose weight, especially in those who have overweight or obesity. And that can be through change in lifestyle, both in terms of what they're eating and their physical activity. In terms of dietary selections, we encourage to minimize ultra-processed foods, sugar-sweetened beverages, in an attempt to really make their diet more healthy and be able to get that caloric deficit for weight loss. Physical activity should be tailored to meet the individual's needs and preferences. In general, the recommendation is aiming for 30 minutes or more of moderate intensity exercise 5 times a week, or having 75 minutes a week of vigorous intensity physical activity. Reducing alcohol use or giving it up completely. We heard Dr. JP talk about the downsides of alcohol, especially from a liver perspective. We know that combination of metabolic factors and alcohol really accelerates disease. So for anyone who has MASLD, the recommendation really is to stop alcohol use, quitting smoking if that's something that they're engaged in. The weight loss goal really should be 7 to 10% of their baseline weight. Next, we also know that we have now 2 FDA-approved medications to treat MASH with fibrosis stage 2 or 3, and these are semaglutide and resmetirom. So I just wanted to mention those very briefly. But again, the take-home message is have a high index of suspicion, screen, and determine where in the fibrosis spectrum the patient is. I'm going to pass it on.
Good morning, everyone. Again, pleasure to be with you. Thank you for the event organizers for such a great program. I'm going to speak to 3 diseases where my colleagues have had the benefit of speaking only to 1, so over the next few minutes. And I want to really emphasize my most important aim here is really to emphasize your role as primary care providers and patients with rare autoimmune liver diseases. In fact, your role is as important as the hepatologist role, and we'll highlight that as we go forward. So our first slide focuses on primary sclerosing cholangitis, and many of you may remember from schooling that this is a bile duct disease that includes typically both the small and large ducts in a majority of cases, but sometimes only presents with small duct disease. Among those patients with large duct disease, we see it in both the intra and extrahepatic ducts most often, in isolation in a smaller fraction. One key thing for primary care doctors is to think about key demographics as we consider the autoimmune rare liver disorders as well. Specifically in PSC, we typically see a male predominant cohort, typically with a younger onset of diagnosis. But other important factors is the idea that inflammatory bowel disease is quite prevalent in this population as well, particularly at 60% or so at presentation. One of the most important aspects I'll bring across the three diseases we talk about is about the extra baggage that comes along with this disease or these diseases beyond fibrosis development. We see a lot of other comorbid issues, particularly surrounded fatigue and pruritus, which may be the way many patients may present to your office. And critically important is really delaying diagnosis in these patients is really been shown to be impactful in terms of transplant-free overall survival as well. As you think about objective phenomena in those key demographics for PSC, specifically liver test elevation are some of the most important aspects that we look at. And specifically, we'll see this founded in more of a cholestatic picture, meaning alkaline phosphatase elevated relative to liver test AST and ALT. This is often confirmed without the use of biopsy. All we need is really high quality imaging, particularly MRCP or even ERCP. And part of the reason of this is we can actually see radiographic findings that are really establishing in terms of the diagnosis. And diagnosis is critically important as well, as we know that PSC has a markedly increased risk for cholangiocarcinoma and is a part of the follow-up that we do in terms of optimal surveillance with imaging every year. So what I ask you as the primary care doctors is to actually see and identify patients with cholestatic liver injury and think of patients with PSC, but also consider other alternatives, particularly as we think that they had abnormal or normal labs before and transition to abnormal. Then with drug-induced liver injury, considering other viral contributions, but also rule out obstruction with imaging potentially before you get them to the hepatologist. I will promote the idea that PCPs can be very important in terms of management of pruritus, thinking about medications that we use in the clinic like hydroxyzine and bile acid binders such as cholestyramine. Other approaches may be more suited for hepatologists. And as another primary care doctor role, bone densitometry is important for all these three groups, which we'll talk about. Beyond this, GI symptoms should be met with concern and question about concurrent inflammatory bowel disease as well. On top of this, advocacy is really important for these patients. I've placed the PSC Partners Seeking a Cure, which is a patient group that is dedicated to the support of patients, so making sure your patients have online resources that are reputable as well. In primary biliary cholangitis, the key demographics are more centered in the female predominance. We see it a little bit later in onset, but specifically the inflammatory destruction of bile ducts is more in the small setting as identified by chronic granulomatous destruction. Again, these patient population with PBC are more often suited with fatigue, but itch as well. We see a chronic cholestatic pattern with often 90% of patients having the positive anti-mitochondrial antibody and elevated IgM, as well as concurrent sicca symptoms, which is dry mouth and dry eyes. Again, early detection is incredibly important because we have treatments, more specifically for PBC with ursodeoxycholic acid. That being said, for those patients that don't respond well to urso, we now have 2 FDA-approved drugs just over a year ago that we've been able to use in addition to urso to provide better overall outcomes. The primary care doctor, again, their role in cholestatic liver injury when it's PBC, continue to consider the differential in this population of more female predominance, but consider other things such as drug-induced liver injury, viral, obstruction as well, and settle into a treatment with pruritus and to try to provide some benefit to the patient before they get referred to the hepatologist. But also don't forget about bone density, as again, guidelines have identified this as an increased risk with this patient population, particularly those that have other risk factors as well. And very finally, autoimmune hepatitis. This is also female predominant, but again, presents very differently, typically bimodal. This is more of a hepatocellular injury, and again, can be confused with other liver diseases as well. We often see liver inflammation of the interface and the biopsy itself with lymphocytes and plasma cells. We sometimes get concerned that we can confuse AIH with fatty liver because, again, patients with fatty liver disease may also have elevated liver tests in a similar order of magnitude, but also sometimes elevated IgG, and up to a third of them have the positive anti-smooth muscle antibodies as well. So I think clinical suspicion is critical. Continue to consider a referral for patients, but also realize that we would need to be targeting patients that are at risk, particularly in that bimodal distribution, with also family history or their own personal history of autoimmune diseases as well. Consider a lot of other contributions, particularly drug-induced liver injury and other mechanisms of injury from drug that can cause autoimmune-like reactions. But consider treatment with steroids and our approaches in the liver clinic above and beyond when you get the referral. In the meantime, considering bone density in these patients as well. Finally, advocacy, once again, is critically important. The Autoimmune Hepatitis Association is a place that patients can come together, ask questions, but also feel supported as well.
Hi, everyone. Super happy to be here. I echo the sentiments of all my co-speakers. This is a great program, and it's a new avenue for us to talk about and educate people about conditions we're passionate about. So I would like to talk today about hepatocellular carcinoma, and regardless of which of the diagnosis that you previously heard about, ultimately, this is the dreaded complication. It is the 6th most common cause of cancer-related deaths in the world, and its incidence is increasing. Around 906,000 incidents in 2020, expected to hit 1.4 million by 2040. And if you focus on the map that's on the top left of the screen, you can see it is still predominantly a condition that's seen in Asian countries and sub-Saharan Africa. Geographic trends have been evolving, and in the United States, we expect around 42,000 deaths per year by 2040. The risk factors are all the conditions you already heard about: cirrhosis from any of these causes, whether it's chronic viral hepatitis, alcohol-related liver disease, MASH, or other causes of chronic liver disease. Next slide. So here I'm looking at it from a primary care standpoint and trying to look at what you can do across the spectrum of the natural history of liver cancer. Primary prevention is what we can do even before the diagnosis to try and prevent cancer. And I think there's a huge role here in early detection. And I'll briefly touch upon staging and management, which predominantly is in the realm of the specialist, but it'll be important to understand what options are available. So let's first focus on the leftmost box in the screen, which is primary prevention. You heard about some of these in the previous talks. All of these efforts can decrease the risk of progression of liver disease and thus prevent liver cancer. Hepatitis B vaccination is one of the most effective mechanisms to prevent both hepatitis B and eventually liver cancer. Campaigns leading to universal vaccination in countries like Taiwan and China have led to significant reduction in liver cancer. Hepatitis C treatment, another milestone in liver diseases, and effectively treating hepatitis C prevents chronic fibrosis progression and eventually liver cancer. We've also heard about treating alcohol use disorder. Alcohol cessation can prevent progression of ALD and thus liver cancer. In patients with MASH, managing the chronic cardiometabolic risk factors we heard about, again, has the same effect on preventing fibrosis and liver cancer. There is some limited evidence. It's not currently part of guidelines, but there is evidence both from preclinical and trial data suggesting that coffee use, aspirin, statin, and metformin can have beneficial effects on preventing liver cancer. So this is in the realm of primary prevention. If we move on to patients who are at risk for liver cancer, this is a very well-defined population, and 90% of liver cancer occurs in these high-risk groups. So we have a very nicely defined denominator where surveillance can be effectively used for early detection. The question is, who do you screen? The simple answer is anyone with cirrhosis. If you have patients in your clinic who have advanced fibrosis and cirrhosis, please consider enrolling them in early detection with ultrasound and AFP every 6 months. Now, if you have a patient who has advanced cirrhosis, then if they are a transplant candidate, it makes more sense. And there is also a special population we should talk about, which is non-cirrhotic hepatitis B. Depending on where your practice is, you may have a population who have chronic hepatitis B. And this is a very interesting subgroup because even if they don't progress to cirrhosis, because of the DNA integration, there is a risk for HCC. You need to understand endemic countries, like I showed you in the earlier map, countries that have high incidence of hepatitis B. and also family history of liver cancer. So once you risk stratify these patients, they also greatly benefit, even though they are non-cirrhotic, from being on HCC surveillance. There's increasing data and concern that patients who have advanced fibrosis and multiple cardiometabolic risk factors, like those with MASH or those who have been treated for hepatitis C but still have advanced fibrosis, there's some concern that they could be at high risk, and we decide whether to place them in a surveillance program on a case-by-case basis. If you had to take a very simple message, I would say if you have patients with cirrhosis, please enroll them in surveillance program. It's quite straightforward, ultrasound and alpha-fetoprotein every 6 months. Now, on the right side is how do you stage and manage HCC? I've tried to simplify this into a digestible format that you can still use as a framework when you have patients with liver cancer. You have to stage their liver disease, that's the top panel. You have to stage their performance status, their functional condition, that's the second panel. And the last is stage the tumor burden. And the tumor burden, I would say if it's small and few, but they're all small, you would be early stage. If it's large, but still limited to the liver, it will be intermediate. If it's large and you have vascular invasion or metastasis, it would be advanced. And regardless of tumor burden, if you have advanced liver disease or if you have poor functional status, you would be classified as terminal because those patients can only be eligible for best supportive care. Now, if you have early disease, you're eligible for curative treatments, which is why it is extremely important to place these programs of early detection, because early detection can make you eligible for curative treatments like resection, ablation, or transplantation. If you have liver-limited disease, these can be treated with local therapies like TACE or TARE or SBRT. And for more advanced disease, there's been exciting new development in this field, and these patients are eligible for systemic therapy with a combination of immunotherapy and targeted therapies. So now let's put it all together and see at different stages what the role of primary care can be. Like I mentioned, if you have just chronic liver disease, screen for hepatitis B, C, other risk factors, and modify the risk factors to prevent fibrosis. Since it is not very clinically obvious, always make sure you're staging the fibrosis in your patients so you know whether they have F3 or early stages of cirrhosis. If they already have cirrhosis, continue risk factor modification, make sure they are vaccinated for hepatitis B, and place all these patients on HCC surveillance. Now, once they are diagnosed with HCC, please remember that there are multiple treatment options. From time to time, I see patients who are not referred early enough for these curative options. Transplant criteria have vastly been modified. So anyone with liver-limited disease, consider referral to higher centers for resection, for transplantation. Continue to manage comorbidity so they can remain eligible for these curative treatments. And also for advanced and terminal conditions, I think primary care providers provide a pillar of support for these patients, continue to managing the adverse events, and collaborate with us hepatologists, oncologists as a part of the multidisciplinary management of these highly complex patients who definitely need their primary care physicians on board. Thank you.
Okay, thank you so much to all of our speakers. I don't know about all of you listening, but that was an extremely high yield 40 minutes. I definitely learned a lot and really appreciate all the speakers tailoring their remarks to what primary care providers can do. So I'm just looking to see, okay, there is a question in the chat to start us off. And I think this is for Dr. Lammert. Why is PBC increasing in minorities? Is that the same with PSC?
Yeah, great question. Currently, we don't know. And I think one of the things to be clear about, we think this is a gene-environment interaction, much like is alluded to in a lot of these other chronic illnesses. Only recently have we realized this. And my concern certainly is about the understudying of minority groups. And so part of that aspect is we've honed in on this aspect, concerningly that minorities actually may do worse in some of these diseases as well. Specifically, PBC and autoimmune hepatitis, we know in Black and Hispanic patients, actual overall outcomes are a little bit worse in terms of the response-related treatments. So more to come and hopeful more research in that realm as well.
Great, thanks so much. And while we have you on the stage, Dr. Lammert, I had a couple of questions. I know one thing that comes up and is sort of like the bane of many primary care providers is the dreaded elevated ALK-Phos. Can you comment on, and any other of the panelists, please chime in as well about how to manage that, and is that a lone reason to pursue imaging? And I'll let you
Absolutely.
that.
Absolutely. It's a deep question, and I struggle with it too in my own clinic. So I'll be first to tell you that I get plenty of consults for isolated alkaline phosphatase. Let me ask the audience to maybe consider other sources of alkaline phosphatase before referral to the liver clinic, but also take ones that are serious, particularly those that are paired with symptoms. So we talked a little bit about itch, fatigue, or other systemic type of phenomenon. The other ones is the patients that may even have mildly abnormal AST and ALT along with it. So I think these should be some of your clues that we need to probably do more. Do I think that you need to do dedicated imaging right off the bat? Not necessarily. Again, it depends on your referral site and center and how long it takes to get to a hepatologist. But even just a good run-of-the-mill ultrasound may be appropriate first line for evaluating with someone with just a bland elevated alkaline phosphatase. My last point is a good detailed medical history on top of a history of having normal ALK-Phos can also be helpful. Often I get patients referred from primary care doctors that just overtake someone's care and realize they've had an abnormal alkaline phosphatase for years. Those are the patients that we'd also probably want to see too.
And I do want to add, to what Dr. Lambert said, I think, excellent response in terms of the fact that ALK-Phos is very nonspecific, and that can also be just the first telltale sign that someone has a fatty liver disease. So again, it could run the gamut in terms of the cause, and it's very important that the history and a thorough, review of what the patient had before is done.
Great, thanks. Anyone else want to take on ALK-Phos, or we can move on? Okay, and then folks in the audience, please send your questions. We have a rare opportunity to pick these folks' brains, and I'm going to take advantage of it. So I had a question for Dr. Donna Sakaran. We, like you, in our primary care-based liver clinic, see way too much HCC. I mean, literally diagnosing a case every week, sometimes it feels like. And, being such a preventable cancer, it's tragic, and it's also really motivating to do the upstream work that we can to help prevent development of HCC. One thing we run into, and I know, we represent many different states here. In Georgia, where I practice, we don't have Medicaid expansion, so we have a lot of uninsured patients. And just wondering, in terms of access to HCC care, whether it's local regional therapy or transplant, how do we address that for providers who may be in the same situation that don't have access to transplant care? What can we do in the primary care setting?
Yeah, great question. And yeah, it definitely is heartbreaking how many patients get diagnosed at advanced stages for a disease that has, early detection as a very clearly defined subpopulation who, if they had been screened. I think in the United States, we definitely have a long way to go, and countries like Japan have shown the power of early detection in making patients eligible for curative therapies. So I think that the emphasis on early detection, so that even if not a transplant candidate, they could still be a candidate for therapies like resection or ablation, or even SBRT, and nowadays Y90. A lot of different therapies for early tumors can be curative. So in the community, what I've seen, definitely we have access issues here in California too. There's been a lot of efforts to both educate and also bring more insurance companies into the transplant networks. But the access to interventional radiology, in my experience, is quite widespread in the community. And I do wish that they would get started with some of the therapies, even as they work through helping the patients get the insurance needed for transplant programs. Because what breaks my heart is sometimes it's a small tumor, and the patient's just told, now you have liver cancer, it's palliative care, because there are so many options available that I wish whichever end of the spectrum you can start from to moderate the disease, to temporize to control, to achieve local disease control, so then they're eligible for therapies down the road. Because this, like I said, the number of options, even in the last few years, it's so encouraging as hepatologists and HCC specialists to see the availability of options. And I worry that the penetrance of the availability of these options has not reached widespread into the community, with many people still worrying, oh, now you have a 6 centimeter tumor, so that's go to palliative care. So I wish we would disseminate that more. And it doesn't matter where they start from. Start with a therapy while you try to get access to that curative treatment.
Great, thank you so much. Follow-up question on HCC, and this has come up in our clinic as you all know, the pendulum has sort of swung back and forth on alpha-fetoprotein or AFP as part of the screening guidelines. So it was there, and then it wasn't there, and then it was plus or minus, and now it's plus. So one thing that we've encountered is, what do you do if you get an elevated alpha-fetoprotein in the setting of a recent normal image, say an ultrasound that didn't show any lesion? How do you recommend that PCPs handle that?
Yeah, I think it's a great question in terms of the role of AFP. It's been controversial. It's moved around a little bit, which brings that uncertainty. And I personally feel it's a flawed tool, but it is an existing tool compared to not having, anything. And even for ultrasound, sometimes I've seen patients who miss their ultrasound for various reasons, but it's a non-invasive blood test, which most patients are able to get. So at least you can catch some of them. So from a practical standpoint, I would encourage to continue to use alpha-fetoprotein. There are concerns regarding its sensitivity and specificity and how you interpret it. But I would say the bottom line is we've discussed it to death and we've decided it's part of our guidelines. So it should be used preferably and, in combination with ultrasound because its sensitivity is low. So somehow if you're thinking, okay, I'm getting a 6-monthly ultrasound, patient's fine, you're definitely going to miss some cases. So I would strongly encourage everyone to use ultrasound and AFP in combination. Now, there are these patients who have alpha-fetoprotein elevation, but nothing on the ultrasound, or small lesions on the ultrasound that are non-specific. It's quite a common thing that happens, especially in the context of active viral hepatitis, because alpha-fetoprotein can still go up without evidence of cancer. So I like trending it. So if you see that you treated Hep C and it fell, then you know that it was likely in the context of active hepatitis. We do have 2 other biomarkers, AFP-L3 and DCP. They can also be used in combination with AFP because they bring more specificity. And ultimately, if you have a high AFP, especially if it is beyond 100 and no lesion on ultrasound, ultrasound has its own limitations in terms of body habitus and very cirrhotic nodular livers. So in those patients, I get a cross-sectional imaging for a baseline because small nodules and early HCC can be missed on ultrasound. So I would encourage in those contexts where you clearly see a high AFP to get a CT triphasic or an MRI, just make sure there's no cancer that was missed.
Great, that's super helpful. Thank you. I'd like to turn it to Dr. Arab about AUD. So we've actually just opened a service line in our liver clinic. We're exclusively hepatitis C for a while and then found that we had the capacity to make room for some other liver diseases, so have an AUD treatment clinic. And, I think one thing that comes up, for any kind of liver disease or even in primary care is sort of what is some high impact, high yield, quick to do counseling for patients, around a topic. So whether it's, and I'll ask you this too, Dr. Banini, about MASLD, but, when you have sort of 5 minutes to make an intervention, like what's sort of your talking point that you make to patients that, to really try to convince them about the impact of alcohol on their liver health, and if you have any pearls to share for us.
No, those are great questions. And I think we need to consider that this is a very common disorder, right? So 10% of the population in the US, adult population, will have an alcohol use disorder. It's 9% for women and 13% for males. So those patients are there and probably we are missing them. And many of these steatosis, liver disease are actually ALDs. I think the skill sets for us as physicians, one is brief intervention. So brief intervention is just asking the patient, have you ever considered reducing your alcohol consumption? Or do you know that alcohol may be the cause why your liver enzymes are high? Do you know that alcohol produces liver cancer? Those that are called brief interventions sometimes can make some people make the click. For us as physicians, it's like obvious, right? Would you know that? But the general population doesn't know it necessarily. So that type of brief intervention. And the other one So those are the three questions that I will say. And then the other one is motivational interviewing. Motivational interviewing is trying to pair your agenda with the agenda of the patient. So it's understanding what are their goals. And you know, sometimes an effective intervention is saying, you know, I know that you want to feel better and you are always complaining how you keep gaining weight. You know, alcohol has tons of calories, you know, and that's motivational interviewing is you are taking their concerns and somehow trying to pair it with your agenda. So I will say those are the things, providing the information to the patient and then trying to understand what are their motivations. And the other thing is trying to reduce the stigma. So you are not judging and you tell them this is guilty-free office. So whatever you tell me, I'm here to help you. And then it's also, you need to tackle some of the myths that exist, right? So many people doesn't want to receive pharmacotherapy for AUD because they still think on the sulfiram and that they are going to feel very poorly. And the sulfiram is still used and may be useful in a population, probably not our setting. I will discourage using it in people, especially with advanced liver disease, because it can trigger liver failure. But all the other medications, so you need to tell them now we have more options. These are, you know, if you treat 100 patients like you, this is the chances of being successful versus if you do it cold turkey and without any help.
Great. That's incredibly helpful. I know, you know, in the primary care setting, we're always looking for high yield, brief intervention. So that's incredibly helpful. One more question about alcohol use disorder treatment. So for a primary care provider who may be considering taking on naltrexone after, you know, looking at your compelling data, are there any, you know, safety concerns that they should be aware of? Any, you know, major contraindications, or is it something that they can take on pretty confidently in primary care?
So you know, you need to know that the main side effect is going to be GI discomfort, either nausea or some vomiting initially. But that go away pretty quickly. I think in 2013 there was this black box warning from the FDA on naltrexone and liver disease. That was removed in 2015, but I think it's still all of us 10 years after still think, oh, we cannot use naltrexone in liver disease. We have new data is going to be presented during the liver meeting this year. That even in patients with decompensated cirrhosis, so cirrhosis and ascites, naltrexone is not only safe and effective, but improve outcomes, improve hard outcomes like mortality and further decompensation. So I will say is safe to use even in patients with more advanced liver disease that we thought before. And you need to monitor. It's like any other thing that we use in our patient with cirrhosis. We know that they may decompensate and things may happen, but if you have a close follow-up, should be fine. I have very good experience with naltrexone. It's very easy to take once a day, almost not significant side effects, and the patient like it, and it's effective. So I really encourage people to use more medications for AUD.
Yeah, I agree. And we've been using it in our clinic, and there's actually an IM form as well. So, you know, that can last, I believe it's 3 months. So that's another option for 1 month. Thank you. Okay, and Dr. Banini, if I can turn it to you and pose the same question that JP just answered about the kind of motivational interviewing or any quick interventions that you found helpful in terms of lifestyle changes for patients with MASLD.
Absolutely, yes. Thank you for that question. So about 80 to 90% of patients with MASLD have overweight or obesity. And then the other 10%, you know, has what we call lean MASLD, which is that their BMI is in the normal range. So I think it's important to have patients understand that metabolic risk that increases their chances of having had MASLD in the first place. So definitely a motivational interview, like Dr. Arab said. Patients may have heard for years and decades that they need to work on their weight, but I think it takes a different level of impact when they know that that weight has increased their risk or led to them developing MASLD or diabetes or high blood pressure or high cholesterol. And so if they address that common risk factor, there could potentially be improvement in the other diseases that I just mentioned. And so that really ties into making sure that they are committed to those lifestyle changes that are necessary to then lead to the weight loss. And so a lot of us now in the liver field also have expertise in weight management, especially because we know the impact of weight management on liver disease. So just quickly in terms of weight management, aiming for that caloric reduction. So just kind of think about, there's no one size fits all and there's no formula to it, but look at what you're eating on a daily basis. Is there ways to cut out calories? That extra soda that you drank, do you really need it? The alcohol that you take at nighttime, just like Dr. Arab said, do you really need it? So, extra chips, do you need it? So think about how you can decrease the caloric content that you're taking on a daily basis. Increase your physical activity, both from a weight loss perspective and also to increase your cardiometabolic health. Aim to have moderate intensity exercise at least 30 minutes a day. That could be brisk walking. You don't have to be a gym member to exercise. So there's plenty of things you can do. Put on, a video on your YouTube channel and work out. Have fun. It doesn't have to be like, hard, strenuous work to do that. Cut out any alcohol. Again, I think Dr. Arab and I are on the same page because alcohol adds extra calories and it really, I don't think that you're getting a much benefit from it. If anything, just detrimental. So caloric restriction to lose weight, increase your physical activity, and take out alcohol from the equation.
Perfect. Thank you so much. I know I always go for the lowest hanging fruit, I feel like, in counseling my patients, which is, no liquid calories. I feel like it's easier, to give up those calories than some food calories sometimes. So I usually start with that. I agree. And then I think we have time for one last question. I'm going to pose it to you, Dr. Banini. I know that, and we've been trying to incorporate this into our, teaching our primary care, our residents in the outpatient setting, but the recommendations are for people with prediabetes and diabetes now to have a FIB-4 checked to do that risk stratification for advanced fibrosis. And I'm curious what you would recommend for, and because when you do the FIB-4 calculation, age is in the numerator. So if somebody's very elderly, they're going to have a higher FIB-4. So what do you do in the case when you're screening like that? Somebody has a high FIB-4, but they've never had any imaging. Do you go to imaging first? Do you go to a FibroScan or ELF score? Can you comment on that in 2 minutes?
Yes, of course, yes. That's a great question. And like you said, on the ends of the, age spectrum, FIB-4 is not great. So above 65 and then under 35, it really is not a great tool for screening. So I have a lower bar to then go for imaging, do a transient elastography and get a sense of where in the fibrosis spectrum the patient falls. A more sensitive specific test is the MR elastography, but of course it's more expensive than the transient elastography that you can get from ultrasound elastography or FibroScan. But if that's something that is available, I would go for that as well. And again, just keeping in mind that there's so many other things that can lead to fat in the liver. You don't want to be missing a chronic hepatitis C, right? So the guidelines now that really everyone should have hepatitis C antibody screening and also screening for hepatitis B. So those also, for instance, chronic hepatitis C genotype 3 can actually lead to increased fat in the liver. So you want to keep your mind open, especially in the beginning. Make sure there's no other modifiable risk that is causing their hepatic steatosis. And then if this is all metabolic related, then you do those strategies that I mentioned in terms of, improving cardiometabolic risk, reducing weight, and taking away any other risks, alcohol and such.
Wonderful. Well, I think we are closing in on the end of our hour. I just want to thank all of our speakers so much. Like I said, learned a great deal and really appreciate everybody taking the time to impart their knowledge, and want to thank our audience too for being here. And I will turn it over to Morgan to close us out.
Well, I would love to reiterate what Dr. Miller just said. I appreciate all of our providers for being with us today, and special thank you to Dr. Miller for stepping in such short notice to cover our viral hepatitis portion as well, and for being such an excellent moderator. For all of our attendees, we also invite you to connect with us on social media and stay in touch. You can find us on Facebook, Instagram, LinkedIn, X, which is formerly known as Twitter, as well as our YouTube channel. We truly look forward to engaging more with you all. Have a great rest of your day.